Guillain-Barré. Gleason, that's it. The movie's called, I think, just Gleason. The movie's called Gleason, I think. Okay, Guillain-Barré. It's a acute demyelinating ascending polyneuropathy is the other name for it. Guillain-Barré. Anyways, but it's an acute ascending or demyelinating ascending polyneuropathy. Usually begins at the toes and works its way up. Not in all cases. In some cases, they can be also a bulbar onset, and those are the cases where you more likely get a diaphragm paralyzed, and then the hospitalization, obviously. That's very rare. Really, it's usually the ascending. So it comes from the feet, it works its way up. Bilateral, so it's bilateral. It's a clinical diagnosis in general. Yes, you can do an EMG, but what is it usually caused by? Does anyone know? Viral infection.
Virus.
And honestly, if you guys ever test like in what virus causes most of these autoimmune, herpes is a good answer for everything. Literally, herpes simplex, herpes zoster, it's a good answer for everything. Because it's generally true. So after an acute viral infection, two weeks, give or take, you can develop loss of complete function in the feet and starts to work its way up. So usually the person has a history and understand, and when they get to the hospital, they're going to ask. And usually the clinical diagnosis is made pretty quickly, and they start treatment obviously immediately. What's the mainstay treatment? Plasmapheresis. What's the dose of steroids we give? Right, it's a trick question. It's a trick question. So you can do IVIG, right? And you can plasmapheresis, which is really, and you also do supportive care, right? In case it becomes respiratory, and even skin, right? If you can't walk, repositioning is important. Why no steroids? Because it's pretty much the only autoimmune disease that you do not use steroids, and it is an absolute you do not use it. It's been used before, and that's why we know you don't use it. What? I'm sorry. No, it's actually not. Believe it or not, when steroids were used initially, it would retard healing of the axon. So no steroids in Guillain-Barré. That may be a test question. But it's really, it's pretty much the only autoimmune disease you never use steroids for. What do you think happens? The virus causes you to produce antibodies. What cells produce antibodies? The B lymphocytes, right? With this production of B lymphocytes, you have antibodies produced. B cells differentiate the plasma cells, which produce lymphocytes specific for the antigen that it's attacking, right? T lymphocytes encourage that. Opsonization, a couple of it activates complement, multiple other different roles. But basically, your B cells produce these immunoglobulins, which attack the virus, right? Well, they think what happens is that there's loss of self-identification. So basically your body should identify self from non-self, and with this, it's lost. We don't know why, but it's happened. That's why it's almost always preceded by some kind of infection. So then all of a sudden your body produces antibodies that attack self, and it goes to town. And that's basically what happens. That's why plasmapheresis and IVIG is so effective. You're either binding the immunoglobulin that's being produced, IVIG, or you're removing it from the system. Supportive care. Basically about it. Just no steroids, guys, right? Guillain-Barré. Yeah, which part? The whole thing? I'll start with it. Fine. Yeah. It's working, but okay. With Guillain-Barré, basically it's an autoimmune disease which causes you have antibodies which attack self, your myelin sheath, sensory and motor. So it works its way up in the feet in the majority of cases. You do have another form of it, but I'm not going to keep you guys responsible for that form. And it works its way from the feet. It's bilateral ascending. These antibodies that are attacking self obviously destroy the myelin sheath, and you lose complete function for the period that it's not growing back. If you give steroids, it retards the healing process, so it's a no-no. No steroids. The treatment is IVIG or plasmapheresis, because it removes the antibody from the autoantibody, right? It removes it from the bloodstream, or it binds to it. That's what IVIG binds to the antibody, and in most cases, IVIG, IgG in most cases. Oh my God. Which is divalent. These are the binding sites, yeah. That's the tail. So this basically binds to your antigens. And then this, you guys run optimization, so it basically identifies yourself. Then you have complement, which is the protein produced by it's proteins produced by the liver called the cascade. These come and literally make a hole in whatever cell it wants to. So it attaches to the tail. So this basically, what this immune globulin is identifying your own tissue to destroy by your immune system. That's exactly what it's doing. Basically shining a flash and saying, come here and destroy this. And your body acquiesces. Remember, all cells have antigens on the outside, right? Binding sites, basically. This should be no steroids, Guillain-Barré, plasmapheresis. It's an ascending bilateral polyneuropathy. So it affects motor and sensory. And it just goes straight up and takes everything away temporarily. Pretty much most people rebound from it. They do EMG is probably one of the only diagnostic tests they do because it will show zero activity in the area that's affected. Anyways, let's go to myasthenia gravis. Myasthenia gravis, anyone know what that is? Okay, myasthenia gravis. When you think of Parkinson's, what do we think of? Okay, Parkinson's equals dopamine, right? Right. Myasthenia gravis is acetylcholine. Is it autoimmune disease? No, it's autoimmune. And what it does is it attacks. Oof, this is a little more complicated. Okay, so you have your motor nerve endings for the. So this is the end of your corticospinal tract, right? At the very end, you have your motor end plate, which is the muscle now it's affecting, right? And you have little receptors here on the crest. What kind of receptors do you think those are? What is responsible for muscle contraction? Right, acetylcholine receptors. Okay, so there's acetylcholine receptors. So what's going to come out from this? You have little vesicles in this which have acetylcholine. And at the very bottom of the muscle, you have acetylcholine receptors. Does everybody remember, like, how nerve transmission occurs? Negative inside, more positive. Starts with sodium. Cascaded sodium channels cause influx of sodium. If the potential is high enough, it opens voltage-gated calcium channels. Calcium enters. Calcium stimulates this to attach to the end of the nerve end plate and release acetylcholine. The reason I bring this up is I actually I just thought about something interesting to mention. You guys ever heard of botulinum toxin? You guys know how it causes muscle relaxation? Relaxation of muscles? Okay, so you have sodium influx inside the motor nerve ending, which activates this calcium, voltage-gated calcium channels, because there's different kind of channels. It's a voltage-gated. Calcium enters. It helps the acetylcholine vesicle to bind to the outside and release acetylcholine, which then will, this is your acetylcholine, and it binds to this. Botulinum toxin prevents this process. It interferes with the binding of calcium with this, which then allows us to attach to this membrane. So botulinum toxin, that's how it works. Botulinum. So how it relaxes all these little spaces, or men can do it also. Or it can kill you very quickly, because only you need a very small amount, less than 1 microgram to kill you. So it affects acetylcholine release from the motor nerve ending. That's how botulinum toxin works. Okay. Okay, so it's somewhat related to myasthenia gravis. So basically now you have your acetylcholine binding to your acetylcholine receptor. You're producing, again, antibodies to the acetylcholine receptor, and they're always IgG. So you're having IgG, you have your divalent, attaches to these, and it binds to it, right? Can acetylcholine not bind to that? No, because you have these antibodies bound to it. But this muscle cell, this is not what really causes the progressive deterioration in myasthenia gravis. The muscle realizes that there's something wrong with these receptors. So the muscle sucks these back in, called endocytosis, and destroys them, gets rid of them. It thinks, well, I'm just going to get rid of these because they're not working. The problem is, as quick as this is happening, it's not regenerating receptors as quickly. So eventually you have a case where you're losing receptors rapidly, and most of the time the muscle is destroying themselves. This is bound to it, the muscle realizes, sucks it back in, and destroys it. When you have lysosomes in your cells, so it's an acid base that eats up the receptor. So the muscle gets rid of it. So that's what the progressive loss of acetylcholine receptors with myasthenia gravis. You also have the activation of complement too, but that's not as common as anyways. But you lose acetylcholine receptors nonetheless. That's what you lose. With less acetylcholine receptors, you have less muscle contraction. So muscle weakness is what's the initial symptom? Muscle weakness. Does the muscle weakness get better with repeated use? Absolutely not.
It gets worse with use.
Right. So that's one of the hallmarks when you're doing a physical exam. Repeated testing causes more and more weakness. Oh God. Okay, so repeated weakness, progressive weakness with repeated use, one of the hallmarks of it. What muscle do you think it affects initially the most? Ocular. Right. Eyes. %50 to 70% ocular presentation. Ecological muscles. It's a bimodal distribution of this disease. From people in their 20s to 30s, you see it in women. In roughly 40s to 70s, roughly, you see it more often in men. And why this is important, why I bring it up, in these men, you see thymoma. In women, you see, I'm sorry?
5 minutes.
You're right, I know. In women, you see.
What do you see in the men?
I haven't voted yet. In men, you see thymoma. In women, you see thymic hyperplasia. 70% of the time. 70% of thymic hyperplasia. So you don't see a thymoma. You see just enlarging of the thymus gland. Does everyone know what a thymus gland is? It's for maturation of T lymphocytes. And basically, the thymus teaches T lymphocytes not to attack cells. That's what the thymus does. It matures the T lymphocytes. It teaches them not to attack cells. Well, myasthenia gravis does a very bad job. You have cells in the thymus called myeloid cells that are supposed to teach the T lymphocytes not to attack cells. Well, when you have cases where you develop a thymoma or thymic hyperplasia, this process goes wrong. And instead of not attacking cells, they attack cells. And this is actually really important, the thymoma or the thymic hyperplasia. Because you have generalized myasthenia. Oh, I'm going to reset the, no, so I don't have to. I have to log back in, log back out. Do it right now. Oh boy. How do you think? Yeah, I know. It's like. I hope they all lodge millions of complaints. I laugh. It's fine with me. Right. Yeah. No, I'm just gonna honestly, I'm gonna pay for it when I get home because it's not even worth it. What they do? But all you guys need to complain to the assistant dean, seriously. Yes. We'll do the American way. I'm gonna wait a little bit. So we covered that, cover this. Yeah, I know it's kind of funny to have that on. Okay, I hope everybody.
Dr. Egger,
Yes.
I heard the full version of the Zoom is only like $15 a month.
Yeah, I know, but
I'm thinking about wood chip and HBO. I will chip.
yeah, I actually
We'll
requested
buy it for you.
that. I actually requested that from the assistant dean, and I haven't heard anything back. So I'm just gonna pay for it out of my own pocket. Yeah, because it's ridiculous. No, but I don't want to keep. This is a waste of my time too. It's ridiculous. Okay. This is poor planning on the administrative part. No, I can appreciate your guys' frustration. I completely understand. Okay. So with the bimodal distribution, I was saying 20 to 30 is women with thymic hyperplasia, 40 to 70 affects men with thymoma. Basically what you see is most cases of myasthenia are generalized. You have an ocular form of myasthenia gravis too, that pretty much only affects the eyes, but generalized myasthenia gravis is what we're talking about. So for diagnosis, what we're going to test for if we suspect this, right, acetylcholine receptor autoantibody. And that's roughly 85% of people with myasthenia gravis have that. If that's positive, it's sensitive and specific, so we know we have myasthenia gravis. You have other tests like a tensilon test, which is like old school. They give edrophonium or neostigmine and see the symptoms improve. I've never heard of that. I'll write it down, but blood test for acetylcholine receptor autoantibody. You also have tensilon test. And you give so a tensilon test, you're giving a drug to basically see if it releases the symptoms rapidly. More commonly now, we look at the antibody test. This is 85% of people with generalized myasthenia gravis, okay? There were people who did an ICE test, but they're saying that that's actually not valid anymore. There's still neurologists who say that it is, but all the recent studies done say that it's nonsense. Anyways, the other antibody, which is roughly 50% of the other cases of myasthenia gravis, is the musk protein. So 85% are due to acetylcholine receptor autoantibody. So basically, you have an antibody destroying the acetylcholine receptor. The other 15%, you have the musk protein. Musk protein is responsible. In that picture I drew, you have the motor end plate here, and you have the acetylcholine receptors. What musk protein does is it actually it's a muscle-specific kinase. What it does is it actually stimulates the body to produce more acetylcholine receptors. So if you have an antibody against this protein, you have less acetylcholine receptors being replaced. So you're testing for these two proteins, musk and acetylcholine receptor. That's about 100% of cases of myasthenia gravis. About treatment, this has changed. In adults with myasthenia gravis, with generalized myasthenia gravis, adults with generalized myasthenia gravis, you always do a thymectomy. Majority of patients who have a thymectomy, either it cures their myasthenia gravis after a few years, it can be months to years, it cures it, or it reduces the symptoms dramatically. So just by removing the thymus, you have a big improvement, which is a huge change in treatment protocol. Otherwise, you're using steroids, and the mainstay is neostigmine, right? And obviously steroids for exacerbations. What else can you use if steroids don't work? The same things we've talked about. You know, immunosuppressants, azathiopine, cyclosporin, you can use any of those things. But neostigmine and pyridostigmine are the maintenance therapy, basically. All adults with generalized myasthenia gravis, whether or not they're acetylcholine receptor positive, autoantibody positive, thymectomy. I know this is complicated, I know it's, but that's basically the newest guidelines. So acetylcholine receptor positive, 85% of people, but the other percentage will roughly be muscle protein. It's a bimodal distribution. Women 20s to 30s, they usually have, majority of them, 70% plus have thymic hyperplasia. And the reason that's important because it's associated with also thyroid diseases, cancers, things like that. So it's associated with other autoimmune diseases, lupus. So that connection is very important to test for. So if somebody has this, you know, they're not just in a bubble. And with men, it's more likely to be a tumor, a thymoma in men. And that's older men. There's another, which one do you want? No, which one? Oh, she's there. Okay. You have what's called Lambert-Eaton syndrome. They call it Lambert-Eaton myasthenia gravis, but it's not really. It's a paraneoplastic syndrome. It happens mostly in people with small cell CA, small cell lung CA. A paraneoplastic syndrome is basically a hormonal imbalance or disease process that's caused by the cancer itself. SIDH, like that. Lambert-Eaton syndrome is related to, in most cases, a small cell lung CA. And it's an antibody to voltage gated calcium channels. Remember the ones I brought up in the first? It affects the calcium channels in the nerve ending. If it kills the calcium channels, you have no calcium entering the nerve and causing release of acetylcholine. Right? Right. But with this kind of myasthenia gravis, if you stimulate the person more, there's more stimulation, more muscle movement, they get stronger. Why is that? So with the repeated use of their muscles, they get stronger. You have more accumulation of calcium. So with Lambert-Eaton myasthenia gravis, which is related to cancer, you get stronger with repeated use because you have more calcium accumulated. But the symptoms are identical to myasthenia gravis. Okay, let's go temporal arteritis, because it is the most, temporal arteritis is the most common, it's the most common form of vasculitis in the body. What's a vasculitis? Vasculitis. Inflammation of the blood vessels, right, and this affects the temporal artery. The superficial temporal artery specifically, but it's the most common form of vasculitis. What do you think some of the symptoms are? Headache. That is like literally headache. Symptoms. Headache. What else?
Vision problems?
Visual disturbance, right. When somebody has this, you want to be rubbing their temporal area aggressively? No, that would be a bad thing to do. But one of the things when you do a physical exam is that if you suspect this, you can rub them if it elicits more pain. It probably is temporal arteritis, unfortunately. The biggest thing is that 50 years old, males predominantly, presentation with headache and elevated ESR. Erythrocyte sedimentation rate. It's an inflammatory marker, right? Like CRP, ESR. So comes to the office complaining of headache, visual disturbance, physical exam, they have pain on palpation of the temporal area, and you take an ESR and it's elevated. What are you going to do? You're going to send them to a surgeon for biopsy of the temporal artery. So diagnostic. Temporal artery biopsy is a diagnosis, 100% sensitive and specific. If it's positive, the treatment is steroids, or steroids for 2 years basically. And then you wean them off and you see if the symptoms come back. Most people respond to steroids, but if the steroids don't work, you are still symptomatic, then you can use other immunotherapies like cyclosporine and azathioprine are the ones usually next. And those are, unfortunately, they're both toxic. Honestly, you could argue the fact that steroids are probably more toxic in this final analysis. Actually, you know what? Real quick with steroids. If we're giving somebody steroids long term, what do we want to think about? What? Okay, so let's go steroids. And really we're talking about corticosteroids, to be specific. Because you have mineral corticoids too, right? And those are very related to corticosteroids, but they're different. Corticosteroids. Prednisone, prednisolone, I'm not going to write them down, but you have corticosteroids. What are some things they do? They decrease immune system, right? What else? Increase blood sugar.
Hypertension?
Whoa, it's not like that. So it's a secondary form of whatever. You know what? I'm gonna put it. Increased blood sugar. What else? Osteoporosis. Somebody put it.
Hypertension?
Hypertension. How? And you can put edema there too. Why not? How do steroids affect? Sodium. Increases sodium retention. specifically, then water follows, but it increases vascular volume, and that's why it can cause edema also. So it's because it's, right, increases sodium retention by the DCT of the kidneys. It's actually really more reabsorption of sodium, which is pretty much 99% anyways, but even more. With this, you have even more, so you have increased volume, and with increased volume, you have elevation of blood pressure, and that's actually significant. That's a big problem with these drugs. You put somebody in 2 years, their immune system is not as good. They're more likely to be basically a drug-induced form of diabetes. Osteoporosis, why? It thins cortical bone directly. Reduces calcium absorption. So osteoporosis is a big, very real issue. What else does it do?
Increase, body hair.
I'm not so much worried about that. What? Not so much. The next biggest one is actually, think about your gut. What does it do? It's a prostaglandin inhibitor. You know, anyways, right, increases risk of ulcer. It suppresses the amount of mucus coating your stomach. So people who take steroids also get GI bleed. Right. That's a lot of problems, right? Tons. And hypertension actually, that's, you know, I thought when I stress a lot, but really it's a huge problem. So what we're going to do, control some of these things. If you put something, I mean, I know bring up because honestly, most doctors give people steroids in a vacuum. They don't think about anything else. Like they don't try to control the sequelae, which is a problem. I give steroids. I usually put them on I don't put them on a PPI because those are god awful. I put them on an H2 antagonist. My choice is usually famotidine. So you're thinking preventatively here, right? Right? What about you going to do the hypertension edema? You're going to monitor them, make sure if their blood, because if they do require treatment from this, because at some point you may have to treat that. Absolutely, unfortunately. How about the blood sugars? If their blood sugar goes up, you have to monitor that too, right? These are things you're if you're giving a patient this drug for 2 years, or you inherit this patient and they want you to monitor their temporal arteritis, and you're giving this and you're prescribing the steroid, you inherit that responsibility. Doesn't matter if the other doctor wasn't or the other provider wasn't doing it. You will have to do that. So you monitor their blood sugar. Let's say it becomes elevated. And the first drug of choice would really be metformin. Immune system, you monitor for infections, right? They're a lot more prone to it. Osteoporosis, what are you giving these people?
Calcium, vitamin D.
Calcium and vitamin D, right. You honestly never see this done. It's crazy. But you better be doing this. And even in cases, if you have a patient who's really older and has this, you might want to put them on a bisphosphonate. Right. So basically, you're watching for all these. So you're basically giving a drug because you have to, for temporal arteritis, you have to treat it. But you also have to be responsible for some of the side effects you're causing with the drug. So the unfortunate part is you can cause multiple issues that the patient may not have by giving them treatment, which you're responsible for the side effects too, and explaining them to them. Listen, this may happen. So I might, so you might listen to the and say, hey, I want you to take this much calcium, vitamin D, and famotidine, and this is why I'm giving it to you because this drug causes all these issues. And then you document that you explain that to the patient because if it comes back to you in court, some guy has a GI bleed, and they say it's because of steroids, and they can make that claim. You better show that you document that you educate them about that, and they can refuse the famotidine. Doesn't matter. Document that you offer to them. Yeah. Or you offer to them, they may not take it. Right. Right. It's a secondary form of diabetes. Yeah. You wouldn't say diabetes. It's a drug induced. Now with the new ICD-10 code, you can have there's more specificity in terms of diagnosis. But they're type 2 diabetics. I mean, yeah. You could argue it's not necessarily wrong, to be honest with you. But it's in that little bubble, but it's not necessarily wrong. a drug-induced form of diabetes, but it's still diabetes. It doesn't matter. It's still it's going to cause the same damage as any other kind of diabetes. Okay. What am I talking about? What is? Oh, temporal arteries. Okay. Bell's palsy, Stu. Bell's palsy is. Oh boy. We're talking about what cranial are we talking about? I got my hands filthy. What's the most common cause of Bell's palsy? Herpes. Have I mentioned that before? Okay. Viral infection usually precipitates this. And you know what the big thing with Bell's palsy, believe it or not? Another big thing with Bell's palsy besides viral causes, viral infection. Labor. Yep, absolutely. We don't know why, but it happens. Yeah. Labor. And people, and I've seen obstetricians like, oh my God, the patient's having a stroke. They have no clue. It's ridiculous. But labor. I mean, it's out there. So, but it's affecting the cranial nerve 7, autoimmune destruction or damage of the cranial nerve, of cranial nerve 7. So everything that cranial nerve 7 does can be affected, and it's It has 5 branches. 1, 2, 3, 4, 5. It has motor, autonomic, and sensory portions, but but basically these are the things you're going to see. You're going to see what are you going to see? Unilateral facial what? Droop. Ptosis, right? So you can't close the eye open. To exacerbate this, cranial nerve 7 also innervates the lacrimal gland. No tears. The air, it's the stapedius muscle. The reason all these symptoms will happen pretty much in most cases. So it's a good quick differentiating tool to know a lot of this, because then you'll know it's not a stroke. It's so specific that it's affecting the stapedius muscle is a muscle in the air that helps to close over the middle air to reduce sound. If this is paralyzed, sound on the affected side is louder. Equals louder. Your parotid gland. Decreased saliva. It also innervates anterior 2/3 of taste, gone. No taste. That's pretty much it. Which is a lot, right? That's a lot. And of course, every motor portion of this is gone too. So it resolves, Right. And it's important because when you get the steroids, it's important. It's why you identifying this quickly and getting steroids within 72 hours is completely unnecessary. Because your doctor doesn't know what he's doing.
What's completely unnecessary?
The truth. They've done all the recent studies for giving antiviral with absolutely no benefit, no clinical benefit. Every study they've done with all the studies which are class A studies, which are really the highest amount of validity, acyclovir does nothing. Nothing. You still see it given, yes, but it doesn't have to be given. I'm just because why give a person an antiviral if you don't have to? It actually shows no efficacy. Why would you give it? Because it's it causes by herpes virus. Let's give it. Okay, it doesn't work. I believe in following like the most recent practice. That's why I get I get Journal Watch. I get everything. I have New England medicine come to my house. I read every night because I want to stay on. You see a lot of things still being done. Doesn't mean it's right. And I know you have clinicians. No, acyclovir. You get it. No, you don't. It resolves anyways. And honestly, without treatment, it usually resolves also. Okay. Okay, let's try to cover dizziness. Dizziness. Okay, dizziness is a big thing. Because it's really common. Oh my God. Oh crap. I don't know. Okay, dizziness can be caused by the peripheral nervous system or the central nervous system. Or the central nervous system. Right? Central causes the dizziness. Has anyone heard the Dix-Hallpike maneuver? Okay. I was going to call you over, Natalie, but no. Basically, you have the patient sitting up. You angle their head, especially you want to, whichever side you think is the affected side you want to do first, because it hasten your diagnosis. So you angle it 35 degrees and you lay the patient back, and you want a table where their neck can hang off the table. Very slight, and then you watch their eyes, because you're watching for what? Astigmatism, right. It'll go to the affected side if it's positive. The moment you do that test, you know it's a peripheral cause of dizziness. In most central causes, you won't have that. So Dix-Hallpike maneuver. So if it's negative, if a person has dizziness and this is negative, you know it's CNS. Automatically, that's a CNS cause of dizziness. The most common cause of this, anyways, is this by far. Benign paroxysmal positional vertigo. And with the central nervous system cause, it tends to affect older people, and they tend to have other neurological symptoms, right? So these are things you want to keep in. If somebody comes in, a 72-year-old guy comes to the office, and he's like, I'm dizzy all the time, and then he's like, if you had a stroke, I had a stroke. He gets his record, and he's had 3 cerebral or medulla infarcts in the brainstem. Shit, it's the strokes, You know why he's dizzy. Doesn't mean you can't have a concomitant cause of dizzy. You could have BPPD, because older people tend to fall more. And when you fall, hit your head, you end up usually getting that. Traumatic, or it can just be spontaneous. But CNS, you look for other neuroscience, signs and symptoms, right? Dysarthria, anything that can indicate brain damage, right? Dix-Hallpike negative. And the biggie, if the person has vertical nystagmus, it is central. End of story. It's okay, we'll be done before then. Okay, so these are the big, central, I'm not gonna, there's so many causes, vertebral, basilar ischemia, cerebellar strokes, MS, God, the list goes on and on. But I want you guys to be familiar with the peripheral nervous system. But just know there's gonna be a central cause, but again, you want to get your differential, you want to kind of separate this by looking at these things. Other neuroscience symptoms, Dix-Hallpike maneuver, and the vertical nystagmus. are big ones. Okay? Dizziness now. Let me try to do this in a way that make it easier for you guys. Let me think about how to do this. And we're talking about vertigo, right? This is sensation of dizziness. Vertigo is dizziness with the sensation motion, right? Right. And another, oh, you know, one other big thing I have to mention, with peripheral nervous system and central nervous system, add this too. The nystagmus is not fatigable. Fatigable. So, in other words, if I keep doing the disc halt-like maneuver on a patient with not fatigable, that means if you keep testing, if you keep if you do the disc halt-like maneuver with someone that has BPPV, every time you do it, it'll become less and less. The nystagmus will fatigue. Till the third or fourth or fifth time you do it, it'll stop. It's fatigable. And there's a delay in onset too. With central nervous, the onset's usually very rapid. You could have the onset of nystagmus by 20 seconds. You turn the head, you keep watching. That's why they say 30 seconds the minimum you watch their eyes, because the nystagmus can start 20 to 30 seconds after. Okay. All right. So now, this is caused by otoliths. In the inner ear, you have an area which has these little calcium, like little sticks, which help for positional sense. They can be dislodged and go into the semicircular canals. If any of these otoliths get dislodged and go into the semicircular canals, you'll develop this. That's why falling and hitting your head, you can shake some of these things loose, and it goes, and you develop benign hiatus visual vertigo. So it's caused by otolith dislodgement out of the ventricle, if you guys want to know. Which your inner ear is like this. It's like you have your semicircular canals. This is the ventricle. This is the cochlea. This right here, that's inner ear. Semicircular canals, and you have the ventricle and saccule. But right here is where the ventricle is, and you have these otoliths in there, which are basically calcium-like crystals, which can be dislodged and go into the most common, the posterior one, because it's closest to that one, and it'll cause that because it's positional sense. These semicircular canals, if you have these calcium crystals flowing around, it's going to completely destroy your sense of balance. That's going to. For this, there's no drugs. It's called the Epley maneuver. That's it, Epley maneuver. And basically, you do multiple different repositionings to get the calcium crystals out of the semicircular canals back inside the ventricle, and it's curative. Epley maneuver. Who said that? Somebody knew it? Who knew yeah. One big thing with this, how you differentiate from the peripheral forms, hearing loss. With BPV, you don't have any hearing loss. With labyrinthitis, you don't have any hearing loss. With Meniere's, you can have hearing loss, and I'll tell you why in a minute. Labyrinthitis is viral infection, herpes, of the vestibular nerve. So it causes inflammation. It's called neuronitis also. Vestibular neuronitis is another name for it. Vestibular. But it's viral vestibular neuronitis. It's viral infection of the vestibular nerve. Well, the vestibular nerve, if you remember cranial nerve 8, it has two portions. It has a cochlear and a vestibular portion. The vestibular portion is what's responsible for balance and positional sense. If you infect that nerve, you're going to get nystagmus, right? So is the nystagmus going to be continuous, or is it going to be episodic? If you have a viral infection of the nerve, right? You're going to have more of a continuous nystagmus. Continuous. With the BPPV, you're not going to have episodic, right? Episodic vertigo, continuous vertigo. No hearing loss. It's not affecting the cochlear nerve. Not affecting cochlear. And this is just dislodgement of these otoliths back into the sympathetic canals. Meniere's disease. This is caused by increased hydraulic pressure in the endolymph. But increased hydraulic pressure in the air, okay? Increased hydraulic pressure in the inner ear. Unfortunately, the inner ear consists of the vestibule, which is that portion with the sacculoventricle and the cochlea. The cochlea is where your cranial nerve is, right? For hearing. So increased hydraulic pressure in the inner ear is going to affect hearing also. So you have some hearing loss. Positive hearing loss, and it's also episodic vertigo. BPV, episodic. Let's put vertigo. Episodic vertigo. Labyrinthitis, you have more of a continuous because it's actually infection of the vestibular nerve. Meniere is episodic because it's increased hydraulic pressure in the inner ear. Because you have increased pressure in the inner ear, you have compression of the cochlear nerve, so you do have some hearing loss. With labyrinthitis and BPPV, you do not, because it's not affecting that. This is actually a really nice, quick way to assess dizziness in somebody.